Hi, everyone. Welcome. We're just going to give it a few more minutes for others to join us, and then we'll get started. All right, well, welcome everyone. My name's Fiona Lewis, and I'm the Patient Support Liaison for AMAC. I'm pleased to welcome you to this webinar. AMAC is a leading funder of research into bone marrow failure diseases in Canada, and I invite you to visit our website to find out more about our services across the country. So your line will be muted during today's presentation, but you can type any questions you have into the Q&A feature that will pop up if you hover your mouse over the bottom of your screen. We'll address those questions at the end of the presentation, and I'll also unmute the lines then if you'd rather just ask your question out loud. So please note that today's webinar will be recorded and posted on our website probably within the next week. So I'm pleased to introduce Dr. Christopher Patriquin and Dr. Monika Oliver to present today's webinar regarding emergent treatment options in PNH. Dr. Oliver received her MD from the Cummings School of Medicine in Calgary. She then completed both her internal medicine residency and hematology fellowship in her hometown of Edmonton at the University of Alberta. Her clinical interests include thrombotic microangiopathies and complement-mediated disorders with a particular emphasis on PNH. She was the 2021 recipient of the Marshall Elia Fellowship Award in Hematology, which she utilized to complete a fellowship in complement disorders and apheresis at the University Health Network in Toronto. She since returned to Alberta and assumed the position of staff hematologist and clinical lecturer with a cross appointment as apheresis co-lead in the Division of Hematology at the University of Alberta. Dr. Patriquin is an assistant professor of medicine and clinician investigator at the University of Toronto. He attended McMaster University for hematology and a subsequent clinical scholarship in complement-mediated diseases. His primary clinical interests include complement-mediated diseases, including PNH, as well as apheresis medicine. His master's in health research methodology focused on effective trial and observational methods in rare diseases. In 2015, Dr. Patriquin completed an honorary clinical research fellowship in PNH with the NHS National PNH Service in Leeds. He is chair of the Canadian PNH Network, site investigator for a number of therapeutic trials in complement-mediated diseases, serves on the executive board of the International PNH Registry, and is a medical advisor for the NORD-AA-MDS Global PNH Patient Registry. In 2016, he joined the University Health Network, where he's a consultant in hematology and apheresis. So thank you both very much for being here today and sharing your knowledge with us. And I'll turn it over to Dr. Oliver to begin the presentation.
Hello, well, I will get started by thanking everyone for attending and thanking AMAC for having us to speak about our favorite topic, which is paroxysmal nocturnal hemoglobinuria. We'll just start with our disclosures, just noting that both of us are involved in a number of clinical trials that are exploring some of the treatment options that we'll be going over today. So just a little bit about our objectives. So our talk will be structured in two different portions. The beginning portion will be myself, and I'll be exploring the clinical presentation of and the diagnostic approach to PNH. And then Dr. Patriquin in the second half will be discussing the current standard of care for treatment for PNH patients in Canada, as well as data on recent clinical trials of new inhibitors that are in development and some upcoming treatment strategies and opportunities. This is a really exciting time for both patients and prescribers in the PNH landscape. So let's get into a bit of background. So what is paroxysmal nocturnal hemoglobinuria? Well, it's a bit of a mouthful, so we'll be referring to it as PNH from now on. And it's an acquired, ultra-rare, benign clonal abnormality of hematopoietic stem cells. So said differently, it's acquired, which means it's non-hereditary, it's ultra-rare, and it's benign, so it's a non-malignant condition, although it is clonal, and I'll go into what that means in a little bit more detail. The prevalence is estimated to be about 0.5 to 2 million people per year. And it was actually named because of this mistaken belief that hemolysis, or the red blood cell breakdown, and eventual hemoglobinuria, which is the free hemoglobin in the urine, happens intermittently or paroxysmally. And it also happens with greater frequency during the night or nocturnally. Now we know that hemolysis can occur at any time, so it's a bit of a misnomer, but in any case, we still refer to it as PNH. We know that it can affect any age group, but it's most predominantly diagnosed in the third decade of life. And it's chronic, it's disabling, and it's potentially life-threatening, especially in the absence of treatment. So how does somebody acquire PNH? Well, the primary defect in PNH is in the PIGA gene, and this is found on the X chromosome. What we know much less about, though, is why this genetic defect actually occurs. So the mechanism for the gene mutation is still unknown, and there's been some thought about whether it could be acquired because of environmental exposures or other types of exposures, but really we still don't have a good explanation for why PNH develops in some patients and not in others. That being said, we do have a good understanding of what it leads to, and it leads to this uncontrolled, unregulated, unchecked activation of our immune system's complement cascade. And the culprit here is really the absence of these GPI-linked complement chaperones, which normally sit and protect our red blood cells from hemolysis. And so those are described by the term CD55 and 59. Now, PNH can arrive completely spontaneously, just bad luck, or what we call de novo, or it can occur in the setting of an underlying bone marrow failure disorder, so either aplastic anemia or myelodysplastic syndrome, or more rare condition, it can be associated with other myeloid neoplasms. And so for PNH to manifest itself clinically, it has to undergo this process of clonal selection and expansion. And so you see here to the left of the diagram that we have the single hematopoietic stem cell that's affected with this PIGA gene mutation, but then it goes on to expansion. And it's really the accumulation of these extra hematopoietic stem cell clones in our various cell lines that lead to the complications and consequences of PNH. And you can see here, it can affect all of the different cell lines, the erythrocytes, the granulocytes, monocytes, and then to a much lesser percentage, the platelets and the lymphocytes. So how do patients with PNH present? Well, the classic triad that we get taught in medical school is that patients present with a DAT negative or Coombs negative hemolysis. And this means that they present with a type of red blood cell breakdown that's not thought to be driven by autoantibodies. Patients can present with thrombosis, and this can be venous thrombosis, which can occur in the legs or the lungs, or in unusual venous locations. And it can also be arterial events as well. And I'll go into this in a bit more detail. And then the last piece of the triad is bone marrow failure. Patients, of course, aren't going to come into our office saying that they have these three components of the triad. They're going to come in with clinical symptoms. And the most common symptom is fatigue. This is experienced in the majority of patients with PNH, and it occurs irrespective of the degree of anemia. Patients can have dark urine, so it can be red or pinkish, or even more tea or cola colored as hemolysis progresses. They can present with jaundice, a yellowing of the skin, and then cardiorespiratory symptoms like chest discomfort or shortness of breath. Patients can also have abdominal pain or present with renal dysfunction, and there can also be issues with smooth muscle dysfunction and contraction. And so we can see high pulmonary pressures in the pulmonary vasculature, something called pulmonary hypertension, dysphagia, which is a difficulty with swallowing, and then in our male patients, sometimes issues with erectile dysfunction. And then the most disastrous complication of PNH is, of course, thrombosis. A little bit about the complement cascade. So there's a lot to go over here, so we'll just briefly touch on this, but really the big key points to take away are that there's three ways or three pathways that lead to activation: the lectin pathway, the classical pathway, and the alternative pathway. And they converge in this entity called C3, which is the proximal component of the complement cascade. And really, this progresses on further to the terminal portion of the complement cascade, C5, and this is where our current standard of care inhibitors act. And then it leads to downstream activation of the most terminal point of the pathway, which is C5 B9 complex, or the membrane attack complex. And really, we normally have these chaperones or these protectors, CD55 and CD59, which help inhibit or regulate or control the complement cascade. But as we just talked about in PNH, we have the absence of these particular chaperones, and that leads to this cell destruction, significant inflammation, as we have these potent anaphylactic toxins that are released, and chemokines and chemotactins. And then we also have significant thrombosis and prothrombotic activity. So shown again here, we have normal red blood cells on the left-hand side, and these basically are studded with these nice chaperone GPI-anchored proteins, CD55 and 59. In PNH, we lack these proteins, and so we have this naked, very vulnerable red blood cell, and that becomes attacked by our complement system. It releases its contents, including free hemoglobin. So this slide here is really just to tell you how significant of a multi-system, multi-organ disease PNH is. So about 60 to 65% of patients will present with free hemoglobin in their urine and some element of shortness of breath. And then about 30 to 40% of patients will have pulmonary hypertension, chest pain, abdominal pain, or erectile dysfunction. And these numbers are different compared to different, or when we cross-compare different studies, but really just to show you kind of head to toe, there's disease manifestations of PNH. So as physicians, when we're tasked with working up a patient with PNH, we do a number of studies initially. We start with blood work, and we start with our CBC, or our complete blood count with differential. And what we're looking for there is, of course, anemia, so evidence of red blood cell breakdown, but also we want to see if we can get clues related to the other cell lines, so decrease in platelets and decrease in white blood cells, and that might allude to the fact that there might be some sort of bone marrow dysfunction occurring. Bilirubin, the pigment that's responsible for jaundice in the skin, will be elevated. And then LDH, which is an intracellular component released when red blood cells hemolyze. And this is extremely important because it helps us track intravascular hemolysis. And as Dr. Patriquin will allude to, really helps us to understand how much hemolysis is occurring and how effective our treatments are. Reticulocyte counts, these are baby red blood cells released from the bone marrow in as a basically compensatory mechanism to peripheral destruction of our mature red blood cells. Haptoglobin, which is low in this disease, and that's because of bound free hemoglobin. Creatinine, renal studies, and then looking at the cells under the microscope for evidence of schistocytosis, which is obvious evidence of blood cell breakdown. In the urine, we look for evidence of hemoglobin and over time hemosiderin, which can develop. And then looking at the photo here, looking at the progression in the color of urine from normal to completely almost opaque or really dark red color related to the degree of hemolysis. And then we may or may not perform a bone marrow biopsy. If cytopenias are developing and they're concerning us for bone marrow failure, sometimes a bone marrow biopsy is warranted. And that's just because patients may be eligible for some other therapies outside of just treatment for PNH if there's a concurrent bone marrow disorder. And then flow cytometry, this is really what we use to clinch the diagnosis. And this helps us identify the lack of those GPI anchored proteins that are deficient on peripheral red blood cells. So let's dive into flow cytometry just a little bit more, because this is a test that your physicians will probably ask you to get done multiple times, and sometimes it can't be done at peripheral centers. So it's a laser-based technique which detects the expression of surface and intracellular molecules to identify and characterize various cell populations. I'll say it one more time in a way that makes a little bit more sense, but basically it's a laser-based technique which helps us look at blemishes or receptors on the outside of red blood cells, and it helps us sort cells based on abnormal or normal populations. And so I kind of think about it like even like a Skittle sorter, where we're looking at the receptors on the outside of these cells to really identify which cells are normal and which are abnormal. And we employ a particular process called FLAIR, or fluorescent labeled areolysin. And this allows us to specifically detect the absence of CD55 and 59. The degree of GPI deficiency is variable. And so when we look at the red blood cells, we actually characterize them into three separate populations. We have our type 1 red blood cells, and these are cells that have completely normal GPI expression. Type 2 have partial GPI expression, and then type 3 have no GPI expression at all. So those ones are most vulnerable to hemolysis. But really the ideal or the optimal cells to assess PNH clone size are the white blood cells, so the monocytes and the granulocytes. And that reason, or the reasons for that, are twofold. Number one, while the lifespan of a white blood cell is preserved, so unlike the red blood cells that are being broken down by hemolysis, the white blood cells are preserved, so they're a stable cell to look at. And number two, they're not affected by red blood cell transfusion. So you can imagine if a patient comes in, they're extremely anemic and they get a red blood cell transfusion, and then we were to do flow cytometry directly following, we would see a large population of type 1 RBC, so normal GPI expression cells, but that would actually reflect the donor and not the patient. And that's why we like to use the white blood cells. So a little bit more about the clinical significance. This is just a nice schematic by Parker and colleagues, which basically helps us to look at different scenarios and that different scenarios that might show us how these might manifest in terms of their hemolysis. So in panel A here, we have a large proportion of type 3 PNH cells with a very small proportion of type 1, and so we would anticipate a high-grade hemolysis here. In panel B, a large portion of type 2 with partial expression, smaller proportions of type 1 and 3, so this would lead to kind of a minimal to moderate hemolysis. And then in the last panel there, a large proportion of type 1 cells where we would expect more minimal hemolysis because there's really only a small proportion of type 3 there. What we know is that more hemolysis leads to more symptoms and a higher thrombotic risk, and more hemolysis usually tells us that there's a higher percentage, of course, of type 3 cells and greater intravascular hemolysis. So another photo here just of high sensitivity flow cytometry. Here we're looking at granulocytes and monocytes. So those are in the bottom of the screen. We're using FLAIR to basically identify the absence of those GPI proteins. And then we look at different markers that help us identify which population of cells we're looking at. CD14 is a marker on the monocytes and CD24 is on granulocytes. We identify relevant cell populations, and we also want to demonstrate that there's at least 2 lineages that have GPI negativity. This is what this looks like when we get flow PNH results. So it's a little bit confusing, but basically we gate around our population of interest, and then we can basically characterize the size of the PNH clone. So next I'll talk about some of the specific complications or consequences of PNH and a bit of data on each. So let's start with renal dysfunction in PNH. We know free hemoglobin is nephrotoxic, and end-stage renal disease is actually responsible for about 8 to 18% of PNH-related mortality. 65% of patients that were enrolled in the TRIUMPH study, and this is one of our initial studies that looked at C5 inhibitor Soliris, which Dr. Patriquin will go into, they exhibited stage 1 through stage 5 CKD. And actually 21% of those patients had more significant CKD, so stages 3, 4, or 5, which is overt kidney failure. Of 14 patients who had a history of acute renal failure, 5 of them actually required dialysis, but did go on to have partial recovery, but about 21% of patients subsequently developed some form of chronic kidney disease. So next, let's talk about bone marrow failure in PNH. So really, there's a lot of variation in the prevalence of PNH clones in bone marrow failure syndromes. It's varied from as low as 4 to as high as 40% in various studies. And part of this is thought to be related to the discrepancy of different diagnostic methods. So pre-flare, when we didn't have flare flow cytometry, there was different mechanisms and different ways and techniques to measure our PNH populations. And so that's where some of the discrepancy has come from. But Fatizio and colleagues in 2021 published basically a large population, greater than 3,000 patients with evidence of bone marrow failure. And they did flow cytometries in those populations and found that about a fifth of patients in the MDS group did have a PNH clone, and about 2/3 of patients with aplastic anemia had a PNH clone. The vast majority, so about 70% of patients, had a clone that was less than 10%, and of that, 30% had a clone less than 1%. So small clones, but clones that are there nonetheless. Unlike most things in medicine, when you acquire a PNH clone, it actually has the potential to be potentially a positive thing. So a PNH clone of any size was actually a predictor of response to immunosuppressive therapy, as well as positive outcomes after hematopoietic stem cell transplant and a favorable impact on overall survival. So this is diagrams from that paper, which basically show the proportion of PNH clones as they kind of work out in each disease. And what they found is that MDS patients mostly presented with small, so less than 10%, and very small clones, less than 1%. Of course, patients who had classic PNH manifestations had large clones, usually greater than 50%, and aplastic anemia cases had kind of medium-sized clones, 10 to 50%. LDH, as we expect, was significantly increased along with the clone size. So the higher the clone size, the more hemolysis, the more LDH elevation. And from this same study, just looking at the overall survival at 8 years. So in panel A here, looking at the total population and finding out that the group that tested positive for PNH clone of any size actually had favorable overall survival. In panel B there, looking at the variations of clone size and overall survival, but noting that that solid bar, 0% for clone size, they had actually the worst overall survival. And then panel C and panel D, looking at the MDS population and the aplastic anemia population respectively. And again, better overall survival with a small PNH clone size. So let's move to pulmonary hypertension and PNH. The mechanism here is that hemolysis releases excess free hemoglobin, and this free hemoglobin is hungry to scavenge nitric oxide. And nitric oxide is a potent vasodilator in our system. And so in the absence of nitric oxide, we have smooth muscle constriction. That leads to increased peripheral resistance, and then of course to pulmonary hypertension. And so Anita Hall and colleagues, they did Doppler echocardiograms on patients with PNH and found that 36% of them actually had elevated systemic pulmonary arterial pressures. They also looked at a substance called PNH, which is a positive predictor of pulmonary vascular resistance, and 50% of patients had elevated PNH and actually had dysfunction of their right ventricle of the heart. So switching gears to talk about thrombosis and PNH. The pathophysiology is extremely complex, and it's an interplay of the coagulation and the complement cascade. This is one depiction of the relationship. Others have tried to simplify it a little bit more, but it's still, much more complicated than the scope of this talk. And so I'll give you the Dr. Oliver approach, which is much more simplified. So thrombosis is a number of different factors. We've talked about one, which is the impaired nitric oxide bioavailability. 2, we have platelet activation when we have uncontrolled complement. We also have inflammatory mediators, so extremely pro-inflammatory state when we have unchecked complement activation. Our fibrinolytic system, which is our system that breaks down blood clots, is also dysfunctional. And then we also have complement-mediated hemolysis, of course, and endothelial injury, which can occur. And all of these work together to really create this prothrombotic state. Thrombotic events will occur in about 30 to 45% of untreated patients. And usually the typical sites are venous, and the majority are DVTs and PEs, so blood clots in the legs and lungs respectively. But PNH is interesting because it also affects unusual locations. It can affect the hepatic vasculature, something we call Budd-Chiari, and it can also affect the cerebrovenous system, so CVT thromboses, and these can actually preclude the diagnosis of PNH. It remains the leading cause of mortality, 40 to 70% of patients that are untreated or undertreated. And that first recognized thrombotic event can actually be fatal, and actually has an increased risk of death following event of 5 to 10-fold. The relative risk of VTE is extremely increased, and in comparison, it is much, much more increased than our hereditary hemophilias like protein C, S, and antithrombin deficiencies. And we know, and I'll show you in the next slide, that chronic subclinical thrombotic events can go unnoticed, which is scary that there's, chronic blood clots potentially accumulating in patients over time. In terms of the breakdown, about 70 to 85% of cases of thrombosis are venous, and about 15 to 20% are arterial. And in the 20% of cases, they actually involve more than one site at a time. So this was work by Anita Hall and colleagues where they did MRIs on 10 patients with PNH. The average age of these patients was only 32, and they had only had PNH for a total of 2 years. They did have very large PNH clone sizes at greater than 90%, with extreme elevation of the LDH greater than 2,500. But what they found is that 60% of patients, and that you can see in the photo at the bottom, had these subclinical blood clots or pulmonary emboli in the lungs. And 20% of patients actually had evidence of myocardial scarring. So that's extremely concerning, especially looking at the population age, 32, and the disease duration, only 2 years. And so you can imagine that as you increase in age and your thrombotic risk factors increase and your disease duration increases as well, the risk of thrombosis would continue to increase as well. So finally, just looking at the clone size and the thrombotic risk. So patients will often say, why is my clone size so important? And that's because it's just such a strong predictor of thrombotic risk. So looking here and seeing that really as we get greater than 50% of a clone size, that's really when we get the disease manifestations more strongly in our patients, but also that thrombotic risk just increases quite significantly. And so finally, a bit about the distribution of thrombosis in PNH. So again, like I said, about 70% of events are venous, and I'm looking to see that still the majority are DVTs and PEs, but a disproportional amount of these are clots in weird places like the mesenteric and visceral veins, hepatic veins, the cerebrovenous occlusions. And then when we look at arterial events, the majority are stroke, followed by mesenteric artery thrombosis and myocardial infarctions. And so I'll leave you with this before I hand it off to Dr. Patriquin. This is the acronym we sometimes use, which is CATCH. And CATCH is aplastic anemia or MDS, T for thrombosis, which is unexplained, C for Crohn's negative or DAT negative hemolytic anemia, and H for hemoglobinuria. And so we rule if we have patients that are exhibiting these particular symptoms or manifestations, then we should really be ruling out PNH with flow cytometry and clinical assessment. And I will pass it on to Dr. Patriquin to discuss treatment with us.
Perfect. Thank you, Dr. Oliver, and thanks everyone for the invitation. So let's talk first about just general management of PNH. Supportive care is likely to some degree for any patient that may be transfusional support, particularly if there's also bone marrow failure associated with the PNH. Patients may be iron deficient, and we will need to replace that. Everybody we recommend folic acid for to support the bone marrow because it is working harder. And some patients will have significant pain and they may require analgesia, particularly abdominal pain or sometimes even painful swallowing. I won't spend too much time on the transplant side of things. Transplant is reserved predominantly for people who have bone marrow failure that is more out of keeping with the hemolysis. But this is something that can be considered in rare situations. Thrombosis, we already heard about a little bit, and certainly part of what we need to do with any thrombotic event is anticoagulate, put them on blood thinners. However, that's really not enough, and we do need to add a complement blocker, which addresses the underlying driver of that thrombosis, that blood clot. Primary prophylaxis is something that we sometimes need to start, meaning that we put a patient on a blood thinner to protect from a blood clot because we are unable to start targeted therapies such as Eculizumab or Soliris, and that's what we'll talk about next. Sorry about that. So Eculizumab or Soliris, this is an IV medication that has been around in Canada since 2009. It's given as an IV infusion for the first 5 weeks. That 5th dose is a higher dose, and then it's given every other week after that, long-term, as long as that PNH clone is present and causing symptoms. It is usually quite well tolerated, although the main thing that we do have to watch for is risk of meningococcus, which can be either meningitis or it can cause bloodstream infections. And it is mandatory that patients be vaccinated as broadly as possible with the 2 vaccines we have available in Canada. And in many cases, we will also continue long-term antibiotics. If not, we will provide rescue antibiotics, particularly if the long-term antibiotics can sometimes cause stomach upset and other side effects. The slide here shows you essentially what Eculizumab. I'm so sorry here, having some issues with the technical side of things. The slide here shows you a composite of the clinical trials that led to Eculizumab's approval, the Triumph, Shepherd, and EGASUS studies. And this shows you the LDH on the left side, the y-axis. And as Dr. Oliver mentioned, this is one of the main things that we focus on in PNH because we want to ensure that that LDH is as low as possible because it is a reflection of intravascular hemolysis and the downstream effects that it can have. This blue line at the top here shows you the placebo arm of the Triumph study. And then at week 26, they too were given active drug. And you can see again that the LDH returned close to normal. And not only does Eculizumab improve quality of life and reduce symptoms, it also extends quantity of life. It improves survival. And to put this in context for you, on the left, this is the natural history paper that looked at PNH survival in 1995 for patients who did not yet have complement therapy available to them. And the 5-year mortality rate was 35%, which is very significant, particularly as the median or average age of diagnosis for these patients is in the 30s to 40s. If we then compare that to the slide on the chart on the right, this shows you that the curve is almost overlapping the age and gender matched normal population for a good majority of time with a slight drop off around 10 years. And that's reflecting progression of bone marrow failure, such as aplastic anemia, which Eculizumab, Soliris, and really no complement inhibitor would be able to prevent. And one of the main reasons that we think survival has improved significantly with Eculizumab is the reduction in thrombosis. And thrombosis, again, is a major concern in PNH, particularly if it's untreated or undertreated. And when we looked at the pilot study, the Triumph study, and the Shepherd study, which all led to Eculizumab's approval, we saw that there was significant reduction in the risk of thrombosis with a relative risk reduction of 85%. And that was even higher in some subgroups of patients. Sorry, I'm having some issues advancing. One moment. And what to expect from Eculizumab, some of you on the call may be on this, and maybe you have had a similar experience where it might be different. This is very broad in terms of what to expect. Usually around 1 week, we start to see the LDHs coming down, and by 4 weeks, it should be normalized. Between 2 and 3 weeks, we may start to see some improvement in quality of life. Reduction in transfusions happens over the next few months. It takes longer to see those types of effects. And over 6 months, we tend to hopefully see continued improvement in quality of life, improvement in hemoglobin, reduction in transfusion needs, and really most of these, if not all of these outcomes we see continue long-term as long as the drug is on board. The safety profile for Eculizumab or Soliris, the most common side effect is headache, and that happens in about half of patients, particularly upfront. It tends to diminish over time, but it is quite common and is related essentially to that rapid increase in nitric oxide that Dr. Oliver was talking about earlier. The other side effects, which are not infrequent, are nasopharyngitis or upper respiratory tract infections, cold-like symptoms. Some patients will have back pain and nausea, but again, that risk of neiserial meningitis is the main concern for us and the one continued risk needing ongoing vaccination and possibly antibiotics. So let's talk about novel therapies in comparison to what we have with Soliris. I think it's important to first think about why do we need them? And I break it down into 3 C's: complications, convenience, and competition. And from a complications perspective, it's uncommon but possible that some patients just may not have any response to Eculizumab. And that's seen particularly in patients who are of Japanese or Han Chinese descent, because there is a fairly common variant in their genetics that just means that the C5 is different enough that Eculizumab or its related molecule, Ravulizumab, it just can't bind. And so there are new C5 inhibitor therapies that are being designed specifically to address a different part of that C5 molecule so it would work just as well in those patients. C3-mediated extravascular hemolysis, this is something that any C5 inhibitor will essentially drive the production of or the effect. And what happens, as we saw earlier, is that our red blood cells, if they're surviving longer, become coated with this complement. And this coating of complement is quite attractive to immune cells that are in the spleen and liver and other parts of the immune system, leading to the destruction in a programmed fashion of the red blood cells. So this is something that really we don't see in PNH until we start treatment with a C5 blocker. Infection, we just mentioned meningitis, and that is the main concern still with any C5 blocker. However, as we start to use different molecules that are targeting different parts of the immune system, and even if we consider combined therapy, there may be other types of infections that we have to be aware of. It may modify the types of vaccines we recommend, the types of antibiotics, and a lot of that is still unknown to us. Convenience is really important. Now that we've seen that Eculizumab can improve survival and reduce symptoms, we want any of the medications that are going to be approved in the future to do just as well, if not better. But what we also want to do is improve the convenience, reduce treatment burden for patients, because still it is a every other week infusion, which can interrupt and interfere with just wanting to live your life. So administration schedules have been a major focus in some trials, and Ravulizumab is a molecule that is now given every 8 weeks as opposed to every 2. Other formulations and routes will also open up options for patients too. Instead of having to go to an infusion clinic, you may be able to give yourself an injection under the skin. There might even be pills that are approved that can either add to your regular C5 blocker or even take the place thereof. And lastly, from a competition perspective, I'm not an economist, but I would say that more market players may reduce the cost of these quite expensive medications. Certainly what we're seeing already is that there is motivation to improve the trial methodology. So we are going to see likely better evidence, better quality evidence in the clinical trials, because now companies have to compete. And more importantly, from a patient perspective, if one medication were to fail or if an allergy were to develop, it would give us options to switch to instead of just supportive care or considering bone marrow transplant. And I'll touch on some of these medications, most with a focus on Ravulizumab and pegcetacoplan, and with time willing, a couple of other slides as well. So ALXN 1210, the other name is Ravulizumab, and the trade name is Ultomiris. You may have heard of this. This is Health Canada approved. And there were 2 clinical trials that were published in 2019 of slightly different patient populations. The 301 study took patients who had never been treated with a complement inhibitor before, and study 302 were patients essentially who were stable on a labeled dose of Eculizumab. So they had to be on the usual dose, not a higher dose. And patients were then randomized to either their continuation or a new start of Eculizumab, or to Ravulizumab, which is the long-acting drug, which is given on day 1 and then a higher dose on day 15, and then every 8 weeks after that. And then, as you can see here in the extension period, everyone who participated in the initial studies were able to continue Ravulizumab long-term. And these were non-inferiority studies. Essentially, they wanted to see and make sure that Ravulizumab was no worse than Eculizumab. And what they found was exactly that. So this was from the 301 study. So patients who had never been treated with a complement blocker before, they looked at transfusion avoidance as well as reduction in that LDH molecule. And it was positive in both of these accounts, favoring Ravulizumab over the competitor Eculizumab. And the key secondary endpoints, all very important as well: reduction in LDH, change in facet fatigue score, which is one of the quality of life measures we use, breakthrough hemolysis, and also stabilization of hemoglobin. In the 302 study, which was the switch study, the same was found, where percentage change in LDH favored Ravulizumab, as did these very similar secondary outcomes. Very important to particular control of breakthrough hemolysis, they also looked at the circulation of this complement molecule C5, which is what Ravulizumab and Eculizumab block. And you can see in both of these studies, Ravulizumab patients had no elevations of C5 over this borderline, this dotted line here, which is felt to be good C5 control. Whereas throughout the trials, both of them, patients who were taking their Eculizumab did have times where the C5 was elevated, which can predispose the risk of breakthrough hemolysis and associated complications. There was also a sub-study that was done, and some of you on the call might have been participating in this, where patients in the 302, that switch study, had a survey sent that assessed whether or not they preferred Ravulizumab or Eculizumab. You can see some of the statements here. While I was receiving treatments, I was able to enjoy life, and it was rated higher on Ravulizumab than Eculizumab. And if we look on to the left here, you can see some of the other statistics that came out of this sub-study. Over 90% of patients just preferred Ravulizumab to Eculizumab overall. Almost 90% preferred it specifically because of better overall quality of life. Almost 100% of patients preferred it based on their being able to plan activities, which again refers to that longer schedule given every 8 weeks as opposed to every 2. And then not as robust a response perhaps, but almost 2/3 of patients also preferred Ravulizumab based on control of their fatigue. A more recent study also looked at quality of life and burden of illness. Again, we saw slight improvements in facet fatigue and global health status scores, not as good as the averages in the normal population, but perhaps improvement with Ravulizumab using the 2 quality of life measures assessed in the trial. And you can see the symptoms and signs that contributed to that reduced quality of life. And blue, again, is Ravulizumab showing reductions in fatigue, really no difference in breakthrough hemolysis, interestingly, but reductions in shortness of breath, headache, difficulty focusing, and back pain. Although interestingly, sleep difficulties did seem to go higher with Ravulizumab, and the reasons for that are not entirely clear. There was also an assessment from a work productivity and employment perspective, because obviously if you're getting a treatment every other week, that can sometimes interfere with work, particularly if you're not feeling as well as you should be. And there were assessments of absenteeism, which were reduced from 19% in patients taking Eculizumab down to 7% taking Ravulizumab. presenteeism, which essentially means that you have ongoing symptoms of your condition at work, but you do go to work, and that was much higher as well. And we saw essentially the same effect throughout these different conditions and assessments. So it does seem to really support an ability to get back to one's life. And with good news, recently we've seen that CADTH, which is the funding decision maker in Canada, provided a recommendation for reimbursement with conditions. We just don't exactly know what those conditions are yet. So the funding criteria that we currently have are a bit outdated across the different provinces and territories. And it's unclear to us at this point if the same approval criteria will be in place for Ravulizumab, or if it will more closely mimic the inclusion in the trials. The other piece that is still a bit unclear is the Eculizumab dose. So as I mentioned, the two trials only assessed patients who were on standard dose Eculizumab, and about 10 to 15%, if not higher, of our patients in Canada are on higher doses because of incomplete disease control. One of the things that any C5 inhibitor will drive, as I've mentioned, is this extravascular escape hemolysis. And that is because essentially there is now a longer surviving red cell that has more time to acquire these complement molecules on their surface. And this makes them essentially tasty for destruction by the liver and the spleen. And this can lead to ongoing anemia and even transfusion dependence. So blocking proximal complement, as in blocking C3 or other steps where I'll show you, can alleviate this complication. And this was the intent of the PEGASUS trial. This was published last year. Pegcetacoplan, or APL2, is the name of this study. And I'll show you that essentially briefly, patients who were enrolled took both medications. They continued on their Eculizumab and added in the investigational molecule. And then they either continued on one or the other, with then an option to switch to pegcetacoplan if you were randomized back to your standard Eculizumab dose. And the main interest in improvement here was hemoglobin. And you can see during this run-in period, all patients essentially had a significant improvement in their hemoglobin by 27 grams per liter on average. And the orange here shows you the pegcetacoplan arm. So this was quite sustained throughout that 16-week trial period, whereas in gray, the Eculizumab patients dropped back down to where they were prior to starting the run-in. With the open label extension, that did then allow patients to switch to pegcetacoplan, and in so doing, the hemoglobin normalized. Sorry, I'm having some technical issues again. The hemoglobin did increase up to that same level, with essentially the exact same mean hemoglobin increase of 27 grams per liter, which is quite significant. Not surprisingly, that was found to be superior to Eculizumab. They also looked at freedom from transfusion and change from baseline reticulocyte count, which were found to be statistically significantly non-inferior, so essentially just as good. They did not meet that mark when they looked at LDH, and based on the way they planned the statistics in the trial, unfortunately, they were then not able to statistically analyze the difference in quality of life measures, although it did seem to be higher in those patients who are on pegcetacoplan. And the benefit, particularly transfusion avoidance, was seen in 85% regardless of transfusion requirements before coming into the study. So if you came in and you had never had a transfusion before, or if you came in and you were getting transfusions quite regularly, the same improvement was seen. What we're still trying to sort out is the risk of breakthrough hemolysis in patients, and this is going to take a bit more time and experience. The LDH is in these patients who are on pegcetacoplan in the study did go up quite significantly, and it did lead to 3 of the 4 patients discontinuing their study drug, whereas patients in the Eculizumab arm who were considered to have breakthrough hemolysis, most of them did not have significant elevations in the LDH, and none of them discontinued. So there is some work still to be done to figure out the risk of hemolysis and how best to manage that. And in fact, there is now a sub-study of this trial that is looking at strategies to treat acute hemolysis with even IV medications or daily subcutaneous injections of this PEGASUS pegcetacoplan drug. Lastly, I'll just briefly touch on some other targets. Factor D is part of the alternative pathway of complement. It is a rate limiting step. It is also one of the lowest concentration drug complement molecules in the system. And for that reason, it allows for lower dosing of therapies. And because of its structure, it is also targetable with small molecules, meaning that these can be actually turned into pills. And you may be already familiar with this or be aware that this might exist. And there are clinical trials underway right now with this molecule called dinicopan. And we have this available in Toronto, it's also available in Alberta and possibly other sites. But what we are doing here is continuing baseline eculizumab, and then patients are randomized to either 3 times a day dinicopan or placebo with an intent to look at increase in hemoglobin and also assess changes in LDH and of course quality of life, which is of utmost importance. So this trial is underway. And the experience thus far with the early stages of dinicopan assessment really shows significant reduction in transfusions. In all of these patients, you can see any red blood cell here was a day of transfusion, and the number within shows the number of units given. And at the start of dinicopan, you can see the 24 weeks thereafter, there was only 1 patient who required any transfusions. So it is quite promising. And as I mentioned, trials are underway. Another factor D blocker by the same company is now assessing a switch. So instead of adding this on to eculizumab, there is the potential to switch from it or to start it directly as an untreated patient. And there are some patients who will be on dinicopan who will also switch. But again, the intent here is to look at improvements in hemoglobin while still making sure that terminal complement is blocked. And there is a lot of interest in complement inhibitors. I won't go into this in too much detail. Again, factor D is a very popular target right now. Alexion has the 2040 and 2050 molecules, which we will have opening clinical trials soon. And BCX 9930, this is another drug that is given twice a day that blocks factor D. Factor B, I won't go into in any significant detail because unfortunately they didn't come to Canada, but it does not entirely preclude another oral inhibitor for PNH coming to the market in the future. But you can see that there's a lot of interest in activity. So let's wrap up. I think we've shown that PNH is a rare and life-threatening condition with a lot of morbidity and mortality if untreated. And it's important for us as physicians to maintain a high index of suspicion, particularly assessing those catch criteria that Dr. Oliver mentioned. PNH comes from an acquired mutation in that PIGA gene that drives uncontrolled terminal complement activity on our blood cells. And it's important from our perspective that patients with any degree of symptom burden and evidence of PNH be treated, although we are still a bit handcuffed by stringent approval criteria across the country. Bone marrow transplant remains the only curative therapy, as we mentioned, particularly if there is predominant bone marrow failure, such as aplastic anemia or MDS associated. But if there is hemolytic PNH, our treatment goals are to reduce that complement activity, ensure intravascular hemolysis is blocked, and our current standard of care to do that is eculizumab. But as we've just seen, these are some exciting times in PNH with multiple new therapies being treated in Canada and abroad. And hopefully some of these, if not all of them, will make their way to our market. The cost of these medications is an entirely different question and topic, but it remains to be seen how our market will deal with all of these. With that, why don't we end, and thank you very much for your attention, and again, the invitation, and let's open to questions.
Thank you both so much for those updates. I'll just unmute the people on the call, and if any of you have questions, please jump in. Anybody with a question? can also type a question into the Q&A if you like. Looks like we don't have any. I guess you've provided all the information needed and answered all their questions. Sometimes we do get questions after the webinar, so if I do get any, hopefully Dr. Oliver and Dr. Patriquin, you could respond by email.
Please do. Yeah, please let us know.
Okay, great. Oh, I think we have one question. Oh. Wendy, did you have a question? You can unmute your line.
Check of approval.
Check of approval. Everything, we don't have questions because it was so thorough.
Awesome.
Okay. Great. Okay, well, thank you for attending, and thank you so much, Dr. Oliver and Dr. Patriquin, for your time today.
My pleasure. Thanks so much.
Bye-bye.
Bye for now.